What kind of difficulties?
Well, can anybody hear me?
Good morning, doctor.
Good. Yes. Good evening. Good morning.
Yes, sir. Yes, sir. Good evening. I am Dr. Pratima, and our team
Raise your
is.
hand. Wait, which one are you? Are you the lady in red? Yes. Okay.
Yes. Video. Can you see me, doctor? I'm Dr.
Yes, I can. Yes, absolutely. You're the lady with her hand raised. Yes.
Yes. Thank you, doctor. Thank you for joining us. I'll introduce you to our principal, Dr. Sarvana Kumar.
So very good morning, sir.
Good morning to you.
How are you, sir?
I'm good. It's still Wednesday evening here, so the night is young.
Okay, sir. Welcome to SBB, sir, on this platform. Pleasure to have you here, sir.
My pleasure.
And all the people around me are my team. It's Team Pedodontics. The faculty and the pediatric residents too.
Excellent. Fantastic. Now, you also mentioned that other people are, I think you have 130 something people from all over the country, or what?
Yes, doctor. From all over the country, we spread the brochure and the flyer. So as soon as they got to know that it is Stanley F. Malamed, so all of them have registered and they've joined to listen to you.
Okay, so this is not only pediatric dentists. There are a lot of general dentists here too, correct?
Yes, doctor. There are dental undergraduate students, dental practitioners, and pediatric residents and pediatric faculties too.
Good. That's good.
And maybe I think even the oral and maxillofacial surgeons.
Oh, we don't need them. No, I'm kidding. Just kidding. I don't want to get the oral surgeons mad.
Yes. Okay. Another 10 minutes. Shall we start?
Yeah. Not a problem. I'm here.
Yes, sir. Thank you so much.
Okay. I'm going to stop my video right now, by the way. Okay?
Yes, sir, doctor.
Okay.
Yes, sir. That's why I was very particular that they should.
Hello, 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 hello.
Namaste, Vanakkam, welcome to everyone. Thank you for joining us for today's online international continuing dental education program, Pedo Colloquium 2021. I am Pratima GS, Professor and Head Department of Pediatric and Preventive Dentistry at Indira Gandhi Institute of Dental Sciences, Sri Balaji Vidyapeeth, Puducherry. I welcome our principal, Professor R. Sarvanakumar, for this CDE program and request him to welcome the gathering and declare the CDE program open. Over to you, sir.
Good morning, all. It gives me immense pleasure in welcoming you all to the Lay Pedo Colloquium 2021. For what I know will be an informative and a productive one. Indira Gandhi Institute of Dental Sciences, a constituent college of Sri Vidyapeeth, is pleased and honored to host this virtual program in Puducherry. Now, when we have an opportunity to meet and listen to Professor Stanley F. Melamed, I believe that by participating in this webinar, we are in the right place, we are in the right time. So together, let us accelerate our knowledge on local anesthetic consideration in pediatric dentistry. What better than it would be to learn it from the Guru himself? So respected sir, it is with all enjoyment and being of goodness with you, we welcome you to SBV and the platform is yours. Now, madam will be going around with the proceedings. So thank you all delegates for being part of it and being on time. So thank you one and all again.
Mute myself. Share the screen.
Dr. Stanley, shall I proceed?
Yes.
Yeah,
You're going to
just a
say
minute.
something?
Yeah,
Okay.
yeah.
You can see my screen, I'm assuming, though, correct?
Yes,
Okay,
sir.
good.
Just a minute. Just a little housekeeping before we get started, dear delegates. Right now, I have everyone on mute to avoid background noises that may distract you from listening to the lecture. Throughout the presentation, someone will be managing the chat functionality. You can enter your questions in the chat or the comment box throughout the presentation. Now, without further ado, we will turn the time over to Dr. Stanley F. Malamed. Today is a very special day for my team and me. We would want to relive this moment again and again. Stanley F. Malamed is a dental anesthesiologist and emeritus professor of dentistry at the Herman Astro School of Dentistry, located in Los Angeles, California, USA. Dr. Malamed has graduated from the New York University College of Dentistry in 1969 and then completed a residency in anesthesiology at Montefiore Hospital and Medical Center in the Bronx, New York, before serving for 2 years as a captain in the US Army Dental Corps at Fort Knox, Kentucky. In 1973, he joined the faculty of the University of Southern California School of Dentistry, now called the Herman Astro School of USC. Dr. Malamed is a diplomate of the American Dental Board of Anesthesiology, a recipient of the Heidi Brink Award in 1996 from the American Dental Society of Anesthesiology, the Horace Wells Award from the International Federation of Dental Anesthesia Societies, 1997, and the Leonard M. Monin Distinguished Service Award from the American Society of Dentist Anesthesiologists in 2015. Dr. Malamed has authored more than 170 scientific papers and 17 chapters in various medical and dental journals and textbooks in the areas of physical evaluation, emergency medicine, local anesthesia, sedation, and general anesthesia. In addition, Dr. Malamed is the author of 3 widely used textbooks published by C.V. Mosby: Handbook of Medical Emergencies in the Dental Office, 7th edition 2015, Handbook of Local Anesthesia, 7th edition 2020, and Sedation, A Guide to Patient Management, 6th edition 2017, and 2 interactive DVDs, Emergency Medicine, 3rd edition 2018, and Malamed's Local Anesthetic Technique DVD 2004 with an edition of 2, 2012. The textbooks have been translated into 22 foreign language editions. In his spare time, Dr. Malamed is an avid runner, exercise enthusiast, and admits an addiction to the New York Times crossword puzzle, which he has done daily since his freshman year in dental school. Dr. Stanley, over to you.
Thank you. There we go. Let me get this. Well, what happened to the screen? Where did my lecture disappear to? Okay, hang on a second. My lecture seems to have disappeared.
If you,
I'll get it. Hang on.
yes.
I had it up and okay. That's not what I want.
I have a copy if.
No. I have to just get back on the right screen here.
Okay.
Share screen. Here we go. Okay, let's go play. Okay, can you see it?
Yes, doctor, we can see.
Okay, fantastic. Well, whoa. We'll get this right. It's still, there we go. Okay, so again, welcome everybody. Good morning, good Thursday morning to you. Right now it is still early evening here on Wednesday in California. You heard about my background. I am a dentist anesthesiologist, been around for a while. I taught at the University of Southern California full-time from 1973 until I retired from my full-time teaching in the year 2013, but I still do lots of lecturing. Unfortunately, for the last year, it's been Zoom. I somewhat prefer to get on an airplane and fly to India or anywhere. I still enjoy that. These are my 3 books. We mentioned the book on sedation, the book on medical emergencies, and tonight or this morning, we'll be discussing local anesthesia. And my email address. I had sent a copy, a PDF file of my slides earlier, and I'm not sure how they'll be distributed, but you contact the organizer of the meeting and you can get a copy of the slides. But if anybody should have questions for me, we're going to have a little bit of time at the end of the session for Q&A, questions and answers. But if anybody later today or tomorrow, whatever, has any other questions for me, my email address is right there. It's my last name, Malamed, M-A-L-A-M-E-D, @usc.edu. And I will be glad to answer them for you. So we're dealing with pediatric dentistry tonight. Forgive me if I keep on saying tonight, Thursday today. And whether it's pediatric dentistry, adult dentistry, geriatric dentistry, drilling on teeth, extracting teeth, doing soft tissue surgeries can be painful. So the question really I want to start out with is, how do we prevent that pain experience during dental treatment? And there are actually 2 ways that we do this. On the left-hand side, you see the little box that says general anesthesia. On the right-hand side of the slide, the big box that says local anesthesia. And since I know we have in the audience, we have pediatric dental residents here. We also have a lot of general dentists, we have dental students, but there are some misconceptions that people make about general anesthesia. So let me just spend a moment or two discussing it. what we're doing in general anesthesia, whether it's pediatric or an adult, and it doesn't matter what kind of surgery it is, whether it's dental surgery or orthopedic surgery, doesn't matter. We are administering, me, the anesthesiologist, administering either intravenously or gases, inhalation, central nervous system depressant drugs. And what we're doing is we are depressing that patient's brain until they lose consciousness. That is what general anesthesia is. General anesthesia is the controlled loss of consciousness. Now, why are my slides not moving? There we go. So what happens then, after the patient is asleep, the surgeon will walk into the operating theater. And if you see on the left, this is not a dental picture, this is the abdomen. And the patient's been prepared, they're asleep. The surgeon walks into the operating theater, picks up a scalpel, looks at the anesthesiologist. I shake my head yes, which means go for it. He or she picks up the scalpel and makes that incision. Okay, what I want to bring up to you is that under general anesthesia, patients feel pain. Think about it. That scalpel, that incision in the belly, if I make that incision in your belly right now, it would hurt because there's nothing to prevent that pain impulse from reaching the patient's brain. Now, the patient feels pain, but because they're unconscious, they won't remember it. They can't respond to it outwardly. They can't move because they're unconscious. So then the question might logically be, then how do I know that that patient's feeling pain? Well, the answer is simple. How do I know that patient's alive? The anesthesiologist, we can't talk to the patient because they're unconscious. We monitor their vital signs. And amongst those vital signs are the blood pressure and the heart rate. And guess what happens to the blood pressure and heart rate when the surgeon puts the knife into the patient's belly? It goes up. Okay, so again, bottom line, general anesthesia, patients don't remember the pain. They can't respond outwardly to it, but there is a response in the elevation of blood pressure and heart rate. Which brings me to this, is local anesthesia. We in dentistry, we the dental profession worldwide, are the prime users of local anesthetics. Yes, there are physicians who use local anesthesia, dermatologists, plastic and reconstructive surgeons, for example, but our profession are the primary users of it. And local anesthetics are the major class of drugs that actually prevent pain. So in this animation, we have a tooth, a maxillary premolar that's infected. And every time that nerve impulse reaches that patient's brain, they feel a sharp stabbing or dull aching pain. What we're going to do, if you look at the right-hand side of the screen, we're depositing local anesthetic at or above the apex of that tooth. As the drug diffuses into the nerve, the impulses get weaker and weaker. And when the nerve is thoroughly saturated, as you see here, even though that tooth is still firing off, we're blocking the nerve impulse from reaching the patient's brain. The patient no longer experiences pain. And that is what local anesthesia is all about. When used properly, local anesthetics are the safest and the most effective drugs that we have in all of medicine for preventing and managing pain. And I'm going to go off on a little bit of a big tangent, actually, in just a little while, and discuss what happens when local anesthetics are not used properly. So these are the four things I want to discuss in the remaining amount of time we have. I want to discuss briefly the drugs that are available. I want to spend a good amount of time discussing what is now known as local anesthetic systemic toxicity. Another name for this is overdose. We'll spend a little bit of time discussing technique, and we'll spend a more time discussing a wonderful local anesthetic, articaine. So that's my menu, if you will, for this evening, for this morning. Part one, let's talk about the drugs. And worldwide, in dentistry, these are the 5 drugs that are used. Okay, articaine, alphabetically, articaine, bupivacaine, lidocaine, bupivacaine, and prilocaine. And we'll talk about India in just a few minutes. About 3 years ago, before the pandemic, I would give probably about 40 to 50 full day presentations anywhere in the United States, North America, or the world on primarily local anesthesia or emergency medicine. Somebody asked me the question, how many cartridges of local anesthetic are used in the dental profession every year? So I went to the 5 major manufacturers of local anesthetics worldwide. Septodont is one of them, is the major one, 3M, SB, and others. And these 5 manufacturers probably make about 95% of all the cartridges that are made every year. Look at the numbers here. Lidocaine, and these are rounded off numbers, they're estimations, but 1 billion lidocaine cartridges are used in the dental profession annually. Articaine is the second most used with 600 million cartridges, Mepivacaine, 300 million, and then the other 2 locals, Prilocaine, 50 million, and Bupivacaine, 10 million. And when you add this up, look at that, 1,960,000,000 dental cartridges are used in our profession annually. And then also consider the fact that there are some countries, and you're one of them, India, and China is another one, where a good number of locals are used in multi-dose vials. So you're using 2% lidocaine with epinephrine 1 in 100,000 that comes out of a multi-dose vial. But this number in front of you right now is simply the number of cartridges that we're using in our profession. And that is a lot of local anesthesia. So in India, this is what is available. This is what I've been told is available to you to use in cartridges. And that is Articaine with 1 in 100,000, 1 in 200,000 epinephrine, lidocaine with epinephrine 2% with 1 in 80,000 epinephrine, and Mepivacaine 3% plain. All right, and this is, these are 3 very, very nice drugs. So what I want to do then is talk about what I consider to be, and I would think you would also, because even though I'm speaking to the pediatric dentists here. Then we have a lot of other dentists here. We have oral surgeons here. We have whatever specialty there is, plus general practitioners. Most of what we do in dentistry, bread and butter dentistry, restorative work, okay, periodontal procedures, root canal, oral surgical procedures, exodontia. How could you do these? Well, you could without local anesthesia, but I don't think anybody would want to. A patient wouldn't want to be subjected to most dental work without pain control. These are our most important drugs. So what I want to do briefly is just talk about, you see the slide, what is the expected duration of pulpal anesthesia? Because, soft tissue anesthesia is something that comes along automatically. But when you're cutting on a tooth, extracting a tooth, you're doing root canal work, we need pulpal anesthesia. So I've divided this down to 3 categories. We have the short-acting drugs, which provide approximately 30 minutes worth of, I'll use the word working time, okay? Pulpal anesthesia is working time. You can work on that tooth. The intermediate-acting drugs, which will give us approximately 1 hour's worth of working time. And we have the long-acting drug, which gives us 1.5 hours, if not longer, of pulpal anesthesia. Now, those numbers are based upon the bell-shaped curve, also known as the normal distribution curve, which you see here. And you notice the dark blue in the middle. This is the normal response. This is a patient who responds to a given drug the way they're supposed to. So let's change subjects. Let's talk about sedation using a drug called diazepam. Diazepam used to be called Valium in the United States. It no longer exists as Valium, only as diazepam. And if I gave a patient the average dose, 5 milligrams. And why is 5 milligrams the average dose? Because if I had 100 patients, I gave all of them 5 milligrams of diazepam, the desired effect is anxiety control, not to make them sleepy, take away their fear. 68%, which we round up to 70%, would respond correctly. That's why 5 milligrams is the average dose. However, on the left-hand side of the slide, 15% of that population on 5 milligrams, it's not enough. It's not enough. They're still anxious. And that group of patients, the hypo-responders, need 10 milligrams, maybe 15 milligrams. On the right-hand side of the slide, we have the 15% of the population where 5 milligrams is too much. Okay, they need 2 milligrams, they need 1 milligram. But this is the way it is for all drugs, including local anesthetics. So if I say to you that this drug should give you 1 hour's worth of working time, that's the dark blue area. But 15% of those patients will have a shorter duration, less than 1 hour, and another 15% of those patients will have pulpal anesthesia lasting, I don't know, an hour and a half, 2 hours. Those are the hyperresponders. And this is what we have. Okay, so we have one short-acting drug in India in cartridges. We have 3% bupivacaine, approximately 30 minutes worth of working time. You have 2, excellent by the way, intermediate acting drugs, which will give you about an hour's worth of working time. We have articaine and lidocaine, both of which contain a vasoconstrictor. And in cartridges, unfortunately, in India, you don't have bupivacaine, which is the long-acting drug. But you know, if I'm dealing primarily right now with pediatric dentists, and I know that that's not the majority of the audience, but for pediatric dentists, a drug like bupivacaine, which can give you up to 12 hours of soft tissue anesthesia, is rarely, if ever, used in pediatric dentistry. And the reason I think is pretty obvious, the risk of a child chewing on his or her lip or tongue, which is numb. So again, what we have here is bupivacaine, plain, short duration. We have the intermediate duration drugs, articaine and lidocaine, which contain epinephrine. Now, let me address this again towards everybody, but more specifically the pediatric dentists. I have a running controversy with the American Academy of Pediatric Dentistry, and the reason is they have wonderful guidelines on the use of local anesthetics in children. And they quote my book. Okay, now my book has gone now through, it's actually in the 7th edition, and they're quoting my book. This is the column on the right-hand side. They're quoting my 5th edition of the book, and the maximum recommended doses of local anesthetics in my book have changed. So let's take a look at this. Our Food and Drug Administration, our FDA, set regulations, they approve drugs. And the FDA approved maximum recommended dose, let's look at articaine, okay? Articaine, 7 milligrams per kilo, according to the FDA, with no absolute maximum, and we'll talk about that later. Yet the Academy of Pediatric Dentistry does set an absolute maximum of 500 milligrams, but more importantly, go down to lidocaine. FDA, 7 milligrams per kilo, absolute maximum 500 milligrams, but according to the Academy of Pediatric Dentistry, it's only 4.4 milligrams per kilo with a maximum of 300. I've had this running controversy with them for quite some time, and hopefully someday in the future, they will see the light. They will quote the new edition of my textbook as opposed to quoting the old editions of my book. But again, for the non-pediatric dentists who are listening, and if you are treating children, that middle column, the FDA maximum dosages, are very, very important. Okay, for the pediatric dentists, you know these numbers. Okay, you deal with children every day. You know how to calculate maximum dosages. But it's for the other doctors out there, anybody in this audience who is not a pediatric dentist, that middle column is the important one. You need to know how much is too much, when to stop. So I did mention this earlier, one of my earlier slides. Local anesthetics are the safest and most effective drugs in medicine for preventing and managing pain, and the asterisk on the bottom when used properly. So what I want to do is now talk for a while about what can go wrong. And what can go wrong is now known as local anesthetic systemic toxicity. The old name, and it's still used, is local anesthetic overdose. So an overdose, now we're talking about local anesthetics right now, but this slide is true for any drug. An overdose of a drug occurs when the blood level of that drug in its target organ gets too high. Okay, so let's define target organ then. a target organ is the place in the body where a drug exerts a clinical action. All right, so think alcohol. Okay, alcohol, the brain, it's a CNS depressant. Okay, that is a target organ for alcohol. Local anesthetics. The target organs are the brain and heart muscle, the myocardium. And what local anesthetics do in those target organs is they depress them. Now, the brain is much more sensitive to elevated blood levels of local anesthetic than the myocardium. And again, as I just said, local anesthetics depress the function of these target organs. So this slide shows you what actually is happening. Let me just read the bottom for you. This is the usual progression of signs and symptoms of local anesthetic systemic toxicity following an overly large dose of local administered correctly. So we start on the left-hand side with the light blue colored area. And all of these signs, anywhere from dizziness to visual disturbances, to confusion, to seizures, to loss of consciousness. This is all based on depression of the central nervous system. If the blood level gets significantly higher, now we begin to see cardiac effects. Elevated blood pressure, elevated heart rate, irregular heartbeats. If you go to the extreme right-hand side of the slide, cardiac arrest. We rarely get into the right-hand side. It's the blue. When an overdose, a typical overdose of local anesthesia occurs, most of the clinical signs and symptoms, and I would say all of the clinical signs and symptoms, relate to the central nervous system. So on this picture, on this diagram, you see that white horizontal line about 2/3 of the way up, and it says seizure threshold. The red line is the blood level of local anesthetic. Once it gets to that point, that horizontal line, and stays above that horizontal line, the patient will be convulsing. The green line is our usual blood level. In other words, if you're injecting local anesthetics rationally, you're minimizing your volume of local anesthetic, you're injecting it, you inject slowly, you aspirate. We're nowhere near, we're very, very far away from an overdose, which is why these drugs are so safe. So again, the typical overdose of a local anesthetic is a seizure. If you've ever seen an epileptic have what the layperson calls a grand mal seizure, a generalized tonic-clonic seizure is not the name for it, okay? The local anesthetic overdose looks exactly like that. And in fact, you'll see it in just a couple of minutes, okay? But as soon as that blood level gets to that horizontal line where I'm pointing right now, that's when the seizure is going to start. This is Dr. Rudolf Dejean. He is a medical anesthesiologist, since passed away, published this book in 1994. And for a person like myself, this is wonderful book on local anesthetics. This is one quote from his book, from page 276. The brain responds to the concentration of local anesthetic delivered to it by the bloodstream, and it cares not at all how the drug got into the blood. Let me repeat that, okay? It cares not at all how the drug got into the blood. Okay, so that's the problem. We have to, one of the things, and I don't have the time to go into this right now, but keep in mind that we're injecting local anesthetics in the mouth, which is a very vascular area. And we're aiming for a nerve. We're aiming to deposit the drug near the nerve. And the drug is going to be absorbed into the cardiovascular system. Okay, and in very small amounts. But if the blood, and where does it go? It goes from capillaries, it goes into veins, it goes to the heart, it then goes all over our arterial circulation, and then goes to the brain. 14% of cardiac output goes to the brain. And if the blood level of local anesthetic in that blood is too high, then an overdose is going to occur. Here's one way of doing it. Let me just use the word accidental rapid intravascular injection of local anesthetic. aspirate blood, take a look at that, but ignore it and push the drug in. And guess what? You're going to see an overdose. This is going to produce a rapid onset of a very, very serious overdose reaction. The only thing I can say about that is it's preventable. If you give a local anesthetic injection properly, which again means you're going to aspirate at least twice before you give the injection. After 2 negative aspirations, you slowly deposit the drug. We can prevent this type of an overdose, an intravascular injection overdose, essentially 100% of the time. The most common cause, and by far the most common cause of a local anesthetic overdose in our profession, sadly, is giving too much local to a small patient. This is called the Swiss cheese model of human error. And what you see here are 4 blocks, if you will, with circles on it. And even though the circles are not always in the same spot, on rare occasion, those circles on the bottom will line up. So what we're looking at here is small errors. Each of these small errors by themselves are not going to produce a problem. But on that unlucky day, when for some reason they line up, that's when the problem occurs. So let's talk about this. Now, I'm talking about this from experience in that part of what I do, and I live in California where we have 80,000 dentists and we have 200,000 lawyers. So they love suing people. Okay? And I get involved as, in quotes, an expert witness in cases of, well, I teach medical emergencies, I teach sedation, I teach local anesthesia. And over these years, I've been involved with at least 40 cases. I've been teaching now since 1973, so we're talking about 47 going on 48 years. At least 40 cases of overdose of local anesthetic. In some cases, the child died, and I would think maybe perhaps worse is in some cases, the child survived with very, very severe permanent brain damage. And there is a similarity to most of these cases. So let's talk about what these are and what the errors are, the Swiss cheese model, if you will. It's usually a patient who weighs less than 30K. Yes, it can happen in larger patients, but no, it's a smaller patient. And the patient is usually well behaved. Very commonly, the dentist is a general practitioner. And commonly, it's a doctor who's been in practice for only a few years. You learn from experience. You know, I'm thinking there are doctors in the audience who are general dentists who've been in practice for 20, 30 years. You've tailored your practice so that you're doing the things you like. Yeah, when you graduated dental school, you love doing everything, but then you learn that molar, mandibular molar root canal work is very difficult. And there are people out there who are specialists, there are endodontists, horizontally bony impacted third molars. You know what? No, there are oral surgeons for that. So the recent graduate, again, trying to build a practice doesn't really understand. Yes, I love treating children. Hey, you know what? This kid is well behaved. Why not? All right, the child has, their treatment plan is perhaps of the 20 teeth they have, 17 of them need restoration. Some of them pulpotomies and stainless steel crowns, others just, regular restorative work. And the doctor was trained properly. The doctor was told in dental school in their pediatric program that you don't do all 4 quadrants at one time under local anesthesia in your dental office. You don't do that. You do 1 quadrant at a time, or maybe you'll do half the mouth this time and half the mouth next time. But okay, the parent says to you, listen, your plan is to do it in 4 visits. Doctor, I live an hour away. Parking here is very expensive. I have a job. I can't afford to miss 4 days of work. Can't you please do it all at one time? And this is, there's an expression that no good deed goes unpunished. And here's a good example. So to be nice about this, the young doctor with a wide open schedule says, fine. Okay, first mistake right there. Then they select a very good local anesthetic, 3% bupivacaine, plain, no epinephrine. And that's a great medication. I'll talk about it in just a little while. It's a great drug when you're working on a small child in one quadrant. But once you start going into 2 or more quadrants, you don't want to use that drug. And here's the reason. All local anesthetics are vasodilators. So when you inject a local anesthetic into that patient's tissue, the blood supply in that area is going to increase. All right, so that's our second mistake. For the treatment plan the doctor has, this is the wrong local anesthetic. Why do we add epinephrine to local anesthetic solutions? Why? And it's very, very simple. Okay, now these are the 2 obvious answers right here. We get an increase in the depth of anesthesia, we get an increase in the duration of anesthesia. But quite honestly, the most important one is that adding epinephrine increases the safety of the drug by keeping it in the nerve, number 1 and number 2, because more local anesthetic diffuses into the nerve and more local anesthetic stays in the nerve longer, increased depth and increased duration. And the fact that the anesthetic will diffuse out of the nerve into the cardiovascular system more slowly, the blood level is going to be lower. And remember, overdose is based on a high blood level. So adding epinephrine, number 3, to me, it increases the safety is the most important reason for it. And here's a slide that demonstrates that. So in yellow, this is a medical study where they gave infiltration of the drug. And they took bupivacaine plain. They gave the patient a dose of 5 milligrams per kilo, no epinephrine, and the peak blood level was 1.2. Now that same patient comes back perhaps a week later, same dose of bupivacaine, but now with a very small dose of epinephrine, and take a look at the peak blood level on the right, 0.7. 0.7 is safer than 1.2. And the same thing holds true for lidocaine. They gave lidocaine 400 milligrams. If you have a 1.8 milliliter cartridge, that's about 11 cartridges. No epinephrine, peak blood level of 2. Same patient comes back, same dose, now with epinephrine, peak blood level of 1. So adding a vasoconstrictor to your local anesthetic, usually it's epinephrine, adrenaline, it simply makes the drug safer. All right. The first mistake was the treatment plan. The second mistake was the drug, 3% plain. The next mistake, and I just don't understand this at all, is the doctor administered the local anesthetic to all 4 quadrants at one time. I don't understand that. And I have spoken, I speak primarily to audiences of general dentists, but there's always a pediatric dentist or 2 in the audience. And I always ask them this, why? Why would you do this? And the answer is we don't. It makes no sense to do this, but they do. You would inject, let's say you are going to do all 4 quadrants, whatever the reason may be, and there might be a reason for that. You inject the upper right and you work. And just before you finish treating the upper right, you inject the lower right and you work. And before you finish the lower right, you inject the next quadrant. And if you do this, if you give the same amount of local anesthetic over a period of an hour or 2, that drug is going to be safer than giving all 4 quadrants at one time. The anesthetic was given properly. The doctor aspirated, got negative aspirations time 2, and they injected slowly. However, and this goes back to where I mentioned earlier that this occurs most often with general dentists, non-pediatric dentists, they gave full cartridges. Now, at least here in the United States, when we talk from our experience here in the US, most injections given by general dentists to adult patients are full cartridges. Do you need a full cartridge? No, but they do. Now, when you're dealing with primary teeth, and you understand this, a fraction of a cartridge is all you need. So that's the next mistake they made. They injected a lot of local anesthetic. They start working. Everything is fine. About 10 minutes into the procedure, what's happening at this point in time is that blood level on that graph is going up. And about 10 minutes following the completion of the injections, It reaches that horizontal line and the seizure starts. So here's a young lady. Obviously, we're making believe here. We're having the dentist administer lots of local anesthetic to her. Get her mouth numb in all 4 quadrants. And he's going to start working. Now remember, even though she's numb, what's going on is the anesthetic is slowly being absorbed into the cardiovascular system from multiple injection sites in all 4 quadrants. And about 10 minutes into the procedure, the blood level crosses that horizontal line and she will have a seizure. Right? And that's exactly how it happens. That's exactly what's going to happen. So how do we handle it? How do we manage a local anesthetic overdose? And if I were to give you a presentation on medical emergencies, this is the same slide I'd show you. We position the patient properly. If they're unconscious, convulsing, supine with their feet elevated, we will assess their circulation, assess their airway, assess breathing. And what do? We protect the patient from injury during the seizure. We activate emergency medical services. I apologize for having 911. I don't know what the emergency medical number here is in India, but again, we activate emergency medical services. While we're waiting for the ambulance to arrive, our job is to protect the patient. They're convulsing. So one rescuer stands by the patient's arms, one will stand by the patient's legs and gently hold on. You don't want to physically prevent them from moving, but you don't want them to have unrestricted movement. Just hold on to the patient. Now remember, what's going on here is the blood is still circulating. Okay, and we're going to see that after about 1 minute. I'm getting a little ahead of myself. After about 1 minute, that blood level is going to fall below that seizure threshold and the seizure is going to start. But look what it says on the bottom. Rescue number 3, airway. Maintaining an airway during a seizure and especially after the seizure is critically important. Okay, so on the left-hand side of the slide, you see what an airway is supposed to look like. The pink area is the tongue, and you can see the trachea on the right-hand slide, that white cartilaginous tube. The airway is open. On the right-hand side of the slide, however, when a person becomes unconscious, muscles relax. Gravity forces the tongue down, and the airway becomes obstructed. The tongue is the most common cause of airway obstruction in the unconscious patient. This step right here, part of our basic life support, airway management, this is absolutely critically important in any unconscious patient, but I'll show you in a moment how specifically important it is in the management of a local anesthetic-induced seizure. It's called head tilt chin lift. You place one hand on the forehead, one hand under the chin, and you simply lift the chin. Since the tongue is attached to the mandible, if you lift the mandible up, the tongue goes with it. This will, in virtually all situations, open up the airway. And if that's the case, if that is the case, the patient, the victim, the patient will recover with no permanent neurological damage. No panicking, protect from injury, maintain an airway. And the seizure stops. The blood in the brain is continuing to flow. So the blood level goes up and the blood level goes down. And the seizure will stop. Most local anesthetic seizures will last for about 1 minute, perhaps a little bit less. However, and there's always a however, if an airway is not maintained, if the tongue falls back into the airway, the patient is going to be hypoxic, not getting enough oxygen. If the tongue totally obstructs the airway, they're anoxic, no oxygen. At the same time, they aren't getting enough oxygen in, they're not getting enough carbon dioxide out. They are hypercarbic. And what happens then is the amount of local anesthetic needed to induce a seizure, the seizure threshold is lowered. It takes less local in the blood and the brain to induce a seizure. So this graph, 4 local anesthetics, lidocaine, mepivacaine, prilocaine, and bupivacaine, this is the seizure threshold for each of these 4 drugs when the carbon dioxide level is normal. So on the left-hand side of the slide, it says the CO2 level is between 25 and 40. This is what it looks like if the airway is open and the patient is getting rid of carbon dioxide. Take a look what happens when the CO2 level increases. The seizure threshold for lidocaine decreases by 53%, 44% for bupivacaine, 45% for prilocaine, and 50% for bupivacaine. So it doesn't take a lot of local anesthetic to induce a second seizure. And that's the problem. In the absence of maintaining an airway, even though the blood level of the local in the brain is decreasing, the seizure threshold is decreasing more rapidly. It eventually will catch up, and a second seizure of greater intensity and longer duration is going to occur. So how do we handle this, the overdose? Very simple again. Supine position, feet elevated slightly. We will assess the circulation. During a seizure, by the way, the blood pressure and heart rate go up. So that's not going to be a problem. But it's the airway. It is the airway that is critically important. And keep in mind, it is a simple procedure called head tilt chin lift. They will be breathing, absolutely. So that's then look at D. D stands for definitive care. Definitive care, as I said before, is to protect the person from injury during the seizure and activate emergency medical services. Now, the next one down will probably not be available in most offices. But if intravenous access is available, midazolam is a drug that we use for sedation. You perhaps use it in pediatric sedation orally. But midazolam is a benzodiazepine. It's a CNS depressant. It's an anticonvulsant drug. And if you have intravenous access available, we will titrate midazolam to clinical effect. Again, it is not needed very often because if you maintain an airway, the seizure will stop spontaneously. However, if the seizure, I'm sort of going to the extreme, if you will, okay? If the seizure is unresponsive to the intravenous midazolam, this is the newest in our treatment of overdose. It's called intralipid, an intravenous lipid emulsion. And as it says here, it has become the standard for treatment of local anesthetic systemic toxicity. Let me read this to you, okay? Again, I know this is not going to be available in most situations. It might be if you're working in an operating theater, but the American Society of Regional Anesthesia and Pain Medicine states that although lipid rescue is important and should be used, it is not 100% effective and is not a substitute for following dosing guidelines and safe practice. So that would be the last possible thing you're going to be doing if an overdose is going to occur. Again, what you need to do simply is follow the letters on the bottom. Proper positioning, assess the circulation, maintain a patent airway, assess for breathing, and the patient will recover. All right, so let's then move on to a brief discussion of technique. And very simply, a couple of things I want to mention specifically in pediatrics is, the length of needle. In our dental profession, we have 2 standard lengths, if you will. We call them long and short. And, the length of these needles will vary from company to company. But in the United States, a short dental needle is 20 millimeters long. A long dental needle is 32. Okay, which one do you use? And even with an adult patient, this is true. One of the first things that you were taught in your local anesthesia program and in undergraduate dental school or your residency program, you don't want to insert a needle all the way into the soft tissue to its hub unless it is absolutely necessary to do so. So what that means is that if you can use a short needle, 20 millimeters long in the US, infiltration in the maxilla, palatal injections, short needles are fine. But with an adult patient, let's talk about, for one moment, let's talk about a teenager, 17, 18 years old. still in your pediatric dental office, perhaps. The average adult, if you're giving an inferior dental block, an IDB, has about 20 to 25 millimeters of soft tissue overlying that nerve. A short needle is not appropriate because a short needle is only 20 millimeters long. You will go in all the way to the hub. A long needle is what you're going to use in that situation. So again, what it says in the very first line is true. A short needle is appropriate until the anatomy of that patient dictates the use of a long needle. Dosage, you don't need a lot. The younger the child, the less you need. But quite seriously, if you look at my book and the recommended volumes for local anesthetic injections for adults, as a rule, the amount we give to a child is 1/2. Look, the thinner the nerve, the less anesthetic you need. The thicker the nerve, the more you need. All right? And in children, these nerves, whether it's the IDB, maxillary infiltration, mandibular infiltration, whatever, they're not very big. You don't need a lot of local anesthetic. Injections, infiltration. Of course, I mean, that is the easiest thing in the world to do, but just with a fraction of a local anesthetic. And if you want to treat all the primary teeth, and the child only has primary teeth, and you want to treat that entire quadrant, you can do the anterior superior alveolar nerve block, the ASA nerve block. Some people call it the infraorbital nerve block, but the actual name is the ASA. And that'll give you all 5 of the primary teeth. But that's not really, the maxillary arch is really not a problem. On occasion, the first permanent molar may be difficult because the bone of the zygomatic arch, the apex of that molar may be sitting underneath that thick bone. And if infiltration is not going to work, then you can go to the ASA nerve block, which will work. In the mandible, and let's talk again about primary teeth only, infiltration works. Infiltration works. If you want to treat all 5 of these primary teeth, the incisive nerve block, which is called incorrectly, but it's called the mental nerve block by some people, is good. It'll give you all 5 of the primary teeth. You can put in 0.45 mLs is 1/4 of a 1.8 ml cartridge. We try to avoid using the long duration local anesthetics like bupivacaine, but since it isn't available in cartridges in India, that's not going to be a problem. The inferior dental block is not usually required when you're treating only primary teeth. Infiltration does work. But when you have a mixed dentition and you need to give the IDB, the success rate is higher than it is in adults. And the reason is, the most common reason the IDB is missed, and believe me, folks, we miss a lot, it's because the local anesthetic was deposited too low. At the site where the doctor put the local anesthetic in, the nerve had disappeared into bone. But in children, the mandibular foramen is lower than it is in adults. So injecting too low in a child is rare. So the success rate, if you need to give the IDB, is going to be higher. Using epinephrine. So let me just read this and then sort of modify it. Vasopressors, epinephrine, should always be included in local anesthetic solutions unless they are specifically contraindicated by the medical status of the patient or by the duration of the planned treatment. Well, contraindication based on medical status is rare in pediatrics. I mean, the most common, most area would be severe cardiovascular problems, which, yes, you can come across congenital problems in children, but we're talking about the adult who has a sick myocardium, heart failure, status post myocardial infarction, things along that line. You don't see this very often, happily, in children. So let's go back to, that scenario earlier, the Swiss cheese model, if you will. My recommendation, and I know that at my ex-dental school, if you will, USC, they teach it like this. If you're treating a child who has nothing but primary teeth, and you're treating one quadrant, then a plain local anesthetic, in your case, it's 3% bupivacaine, is perfectly acceptable. But once your treatment,
Why do you use Medeocaine for everything?
Unmute. Dr. Stanley, please unmute yourself.
I did.
Yes,
Can you
yes,
hear
yes,
me?
yes. Now we can.
Yeah, I don't know how I got muted though. Okay. But so let's go back to this slide here. If you're treating one quadrant, then a plain local anesthetic like mepivacaine 3% is fine. But if you're treating more than one quadrant on that very young child, whatever local anesthetic you're using, please incorporate a vasoconstrictor epinephrine in that local anesthetic. Let's talk about speed of injection. I said that, accidentally giving a drug intravenously rapidly. So let's go back to the basics, if you will. Slow injection is the absolutely most important factor in preventing adverse drug reactions, more so than aspiration. Now, we talk about this, we have what are called national board exams here in the United States. And one of the questions would be, what is the ideal rate of an anesthetic administration? And the answer for all injectable drugs, all of them, is 1 milliliter of fluid per minute. Now, dentists in the US have a hard time doing that because most of them inject way too fast. And here's the rationale behind that ideal rate. If you were to inject a local anesthetic, lidocaine, mepivacaine, articaine, intravenously at a rate of 1 ml per minute, you would see a mild overdose. Perhaps the patient would be shaking. Okay, they'd have palpitations, but they're not going to be convulsing. They're not going to be unconscious. Now, since most doctors inject too rapidly in 1 ml per minute, which means almost 2 minutes for a full cartridge, they can't do that. So the recommended rate is, if you're going to give a full cartridge, spend a minute. Spend 1 minute. It's not as safe as the other one, but it's still safe. Now, keep in mind also that in theory, you're not giving full cartridges very often. Okay, you're giving a full cartridge on an adult patient if you're doing the IDB, if you're doing the Gaugate's mandibular block, if you're doing a second division nerve block. But if you're doing infiltrations, you're putting in a third of a cartridge. That should take you 20 seconds. Okay, that is not asking a lot. And by the way, injecting slowly, as you probably all know, is comfortable. Okay, so what I want to do now is I want to move on to discuss articaine, because we've got good local anesthetics, but articaine is the newest. Articaine was synthesized in Germany. It was introduced in Germany in 1976. Articaine is the first and still only local anesthetic that was made for us. The original brand names you see in the upper left-hand part of the slide, Ultracaine. Okay, but this is a dental local anesthetics. Every other local anesthetic out there was a medical drug in multi-dose vials. We took that drug, lidocaine, mepivacaine, prilocaine, and put it in dental cartridges. This is our drug. So what I want to do, and I want to talk to you a lot about articaine, because especially in pediatrics, it's a truly marvelous drug. Let's talk about how once the drug leaves the nerve, what happens to it? Okay, what happens to it? And what we're going to be looking at for a moment or two is what is called the elimination half-life of the drug. Now, what that means, if you go to the left-hand side of the slide, if we were to measure the blood level of that local anesthetic in your blood right now, how much time would be needed for that blood level to decrease by 50%? That is one half-life. Now, we normally say that a drug is gone from your body, gone, in 6 times the half-life. Not quite true, but at 6 half-lives for that drug, the blood level is decreased by almost 99%. So the old drugs, the esters, we don't use esters anymore. Oh yeah, we use benzocaine topical, but when it comes to the injectable ester anesthetics, we don't use them in our profession. But here's the thing. The ester type local anesthetics, they're in the nerve, they block nerve conduction. Once they leave the nerve and enter into capillaries, the process of metabolism starts. Most ester anesthetics undergo metabolism in the blood. Look at the half-life for procaine. Procaine is Novocaine, 6 minutes. Tetracaine, 20 minutes. Now, look at the amides, the new drugs, the ones we're using. Lidocaine leaves a nerve, enters capillaries, goes into veins, goes to the heart, goes to the arterial circulation. The amides are metabolized in the liver. And the half-life of lidocaine, mepivacaine, and prilocaine is an hour and a half, 90 minutes. Look at 6 half-lives, that's 9 hours. So when it comes to the risk of local anesthetic, systemic toxicity, overdose, the amides are much more likely to see it than the esters. Now keep in mind, let me go back to that last slide, if I can, and I don't think I can. But the esters, okay, you give 1 cartridge of any of these drugs intravenously rapidly, you're gonna see an overdose. But when it comes to giving it correctly, the esters are less likely to produce an overdose than are the amides. Now, I want to bring this up because very often I will ask an audience, how do local anesthetics stop working? And the answer they always give is they're metabolized. Well, you know what? Metabolism has nothing whatsoever to do with duration of action of a drug. It has nothing to do with it. It's the concentration of the local anesthetic inside the nerve itself. Once that concentration falls below a certain level, the nerve impulses begin to break through and the patient begins to feel pain. So on the top, on the left, you see procaine. In that circle, the blue, this is what is called the ester linkage. This is the linkage that makes procaine and tetracaine ester anesthetics. On the right-hand side of the slide, you have the amide local anesthetic, lidocaine. And encircled in red, you see the amide linkage. Lidocaine, mepivacaine, prilocaine, bupivacaine, all the drugs we classify as amides have that HN, that amide linkage. Look at articaine. Articaine is classified as an amide, but it is actually a hybrid. It has an amide linkage in pink. It also has the ester linkage. Now, what's nice about that is this. Okay, 90 to 95% of articaine is metabolized in the blood. And that leads to this. Take a look at this study that was done by Wolfgang Jakob in Germany, measuring over 90 minutes, 120 milligrams of lidocaine, 120 milligrams of articaine. And you can see how the blood level of articaine decreases so much more rapidly than that of lidocaine. Half-life, lidocaine, mepivacaine, about 90 minutes. Half-life of articaine, 18 to 23 minutes. So I had that top line blank on the last slide I showed you, but even though, again, we categorize articaine as an amide, most of its metabolism is done like the esters. Its half-life is only 27 minutes. 6 times its half-life, 162 minutes, is 2 hours and 42 minutes, compared to 9 hours or longer with the other drugs. And essentially what that means is when it comes to overdose from administering too much local, articaine is so much more safe than the other locals. I don't have time to go into all of this with you. I'm going to discuss the pediatric patients, but it is my personal feeling that articaine is the preferred local anesthetic in pregnant patients, in mothers who are nursing, and in pediatrics. And if you're treating older patients, whether it's teenagers on up, articaine by mandibular infiltration, just like you do in the maxillary arch, just do it in the mandible. has a very, very high success rate for producing pulpal anesthesia. So let's talk about Articaine in pediatric dentistry. And specifically, let's talk about Articaine's use in children under the age of 4. And the question really is why? Why does it say in that package insert, that little leaflet that comes with the drug, under age 4? Or not, it should be used 4 years of age and above. Well, back in 1997, 98, in the United States and the UK, the what are called phase 3 clinical trials. Now, everybody's aware of clinical trials now because of the COVID vaccines. The phase 3 clinical trial for a drug is the big one. It's the one that you have to show whoever your drug regulatory body is that this drug is both safe and effective. Okay, so there were 27 dental schools in the US and the UK involved in this study. And one of the studies, we enrolled patients in our studies who were 4 years of age and above, patients from 4 to 79. But in one of the studies, in one of the papers, we simply took out the pediatric patients, the ones who are under 13 years of age. And what we found was that Articaine was safe. From 4 years of age and above, Articaine was safe. The article was published in the year 2000 in the Journal of Pediatric Dentistry. And that's why the FDA approved the drug to the age from 4 years of age and above. Very simple. So the question then is, can Articaine be used in children who are 3 or 2? Well, you know, even before we got the drug, Canada got Articaine back in 1985. We got the drug in the year 2000. And Gerald Wright, the chairman of pediatric dentists in Ontario, Canada, London, Ontario, published his paper. I'm going to come back to it in just a little bit. But again, this article predates the introduction of Articaine into most countries. Canada, other than Germany, Canada was one of the first countries to get Articaine. But here's a paper published just last year. And this is from the International Journal of Pediatric Dentistry. And it was the use of Articaine in children below the age of 4 years. And what they were doing here is comparing Articaine to lidocaine in pulpotomy in children who are 3 to 4 years of age. And their conclusion, the findings supported the efficient and secure use of Articaine hydrochloride 4% with epinephrine 1 in 100,000 to treat children between the ages of 3 and below 4 years. So 2008, this now goes back almost 13 years, even though 6 is June. Yeah, it's almost 13 years. The use of Articaine amongst dental practitioners. By the way, if anybody after we're done would like a copy of any specific article, just email me. I'll be glad to send you the article. So in this chart, and I have colored in here, the use of Articaine, the preferred local anesthetic in patients who are 2 to 3 years of age, 4 to 6, and 7 to 10. But I want to just zoom in, if you will. I hate that word zoom now, but zoom in on the 2 to 3 year olds. And if you look at Articaine, which is the vertical pink, 16% of general dentists, 10% of pediatric dentists like Articaine as their preferred local anesthetic in children who are 2 to 3 years of age. So, I mean, there's an awful lot of literature that I don't have the time to go through with you right now. But this is the question. I mean, can Articaine be administered safely to children who are younger than 4 years of age? And the answer is, of course, there's no problem. So I want to go back to that article from 1989 from Gerald Wright, University of Western Ontario. Okay, the use of Articaine local anesthesia in children under 4 years of age, a retrospective report. So what they did is they went to 2 pediatric dental offices and they looked at their records, their dental charts. And they found that Articaine had been administered to 211 patients under the age of 4. 29 of these children had received more at that one treatment, okay? They had received more than 1 dose of Articaine. In some instances, the dosages exceeded the recommended dose. Keep in mind that the dose was 7 milligrams per kilo. That's what it is in Canada and the United States for Articaine. It's 7 milligrams per kilo, the maximum recommended dose. And in some instances, it says here the dosages were above that recommendation. And no systemic adverse reactions were noted on the chart or known to the clinicians. And they finished up by saying, the present report provides initial evidence for the use of Articaine in children under 4 years of age. So when I talked about local anesthetic systemic toxicity, I mentioned the fact that most of these adverse reactions occur in patients who weigh less than 30 kilos. Given the fact that Articaine is metabolized in the blood so rapidly, okay, if you administer the drug properly, again, I'm saying avoid intravenous injection, which you can do by simply aspirating and injecting slowly. But when it comes to an overdose produced by putting in too much, this is a safer drug for the reason on the bottom. It's eliminated from the blood much more rapidly. Last year, this is the most recent paper. This is from 2020, April. And it was an article, it was a systematic review and a meta-analysis. The use of Articaine and lidocaine in pediatric patients during dental procedures. And just let me go to their conclusion. The effectiveness of Articaine as a local anesthetic in pediatric dentistry was better than the gold standard lidocaine. It is my feeling that probably within 5 years, Articaine will become the new gold standard. It is replacing, even though lidocaine, again, was 1 billion cartridges, been around since 1948. Articaine, a relatively new drug, already is number 2 at 600 million. So here's my email address one more time in case anybody wants to contact me after we finish our little Q&A session right now. But if anybody wants to contact me, ask me for some of the articles that I've talked about, it's malamud@usc.edu. So again, I want to thank you. I want to thank you, by the way, first of all, for inviting me to do this. It feels now like it should be Thursday morning for me, but it's not. It's still Wednesday evening. So I want to thank you all. And I guess we have some time for some questions and answers. Well, questions from you and perhaps answers from me. So thank you.
Thank you, Dr. Stanley. It was a wonderful presentation. And with your permission, we would like to go on with the question and answer sessions.
Sure. Can you hear me?
Yes, doctor.
Oh, okay, okay.
Sir, am I audible?
I can hear you, but I can hear you now, but I didn't hear anything before.
Thank you, sir. Sir, we have questions related to the drugs, sir, and then
Yes.
questions related to technique and some special situations.
Okay.
So related to the drug, there is a question on whether we have to do allergic testing for children.
Okay. I find that question interesting because once I leave the United States and go into Eastern Europe, Asia, and you're in the middle there, okay? I get that question a lot. The answer is no. Allergy to local anesthetics is, especially the amides, exceedingly rare. And when I'm amazed how often that question does come up in those locations. The answer is no, you don't need to, because the amide locals are exquisitely safe. Has there ever been a true allergic reaction to an amide local? Probably yes. But given the fact that we're administering almost 2 billion cartridges a year worldwide, no, The answer is they're very, very safe. So I would say the answer is no, you do not need to do any allergy testing before giving a local anesthetic to a child. Unless let's play, if they come in and the parent says that my child is allergic to peanuts and this and this and this and this, they've never received a local anesthetic before in most cases. And the chances of being allergic on that first injection are almost zero. If they've received local anesthetics in the past, they've probably had no adverse reaction. Don't worry about it. Don't worry about it. I mean, the locals today are very, very safe when it comes to the perspective of allergenicity.
Thank you, sir. So there is another question related to articaine. Can we use it as an intrapulpal anesthetic?
Sure.
In
You can use
irreversible.
intrapulpal anesthetic. Of course, you can use any local anesthetic as an intrapulpal anesthetic. It doesn't really matter what drug you're putting in. The answer is yes, it can be used. There's no reason to not use it. If you have a cartridge with lidocaine, use lidocaine. If you have mepivacaine, use mepivacaine. If you happen to have articaine, use articaine. I don't think any of them is better than any other in that intrapulpal injection. And by the way, whoever wrote that question, you should contact me because intrapulpal injections hurt. Sadly, I've been the recipient of one. And it's very hard to get away from it hurting. But a different lecture, okay? There are a lot of ways of not needing to use intrapulpal injections in endodontics. Again, I don't have the time. This is not part of my lecture on pediatrics, but if that person would contact me directly, I can send you some information on how to not need to give intrapulpal injections in most situations.
Okay, sir, because that is a concern when we have an irreversible pulpitis, a hot pulp,
Good luck.
when the patient is not cooperating, sir.
Good luck. Good luck. So, I mean, look, seriously, that is the most challenging part of dentistry when it comes to pain control, especially when it's inflamed pulp on a mandibular molar. I go through an entire list of what you should be doing. And I mean this sincerely. At the very bottom of my list, after you've tried every possible thing, it says prayer. Because there is no guarantee. That's the problem. There is no guarantee when it comes to that, especially the infected mandibular molar.
Yes.
I give lots of lectures to endodontic societies specifically on that. It's called the dilemma of the hot mandibular molar.
Yes, sir.
Yeah, it is. That is the toughest pain managing scenario in our profession is that.
Yes. Sir, what is the scope of newer anesthetics like ropivacaine or levobupivacaine, sir?
Yeah, well, that obviously did not come from a pediatric dentist because ropivacaine is similar to bupivacaine as a long-acting drug. And in the United States, I'm guessing 20 or more years ago, it was introduced in dental cartridges and it didn't sell. And the reason it didn't sell is that bupivacaine had been around for years and there was no significant advantage to using that new drug. So ropivacaine is long-acting and levobupivacaine is just another version of bupivacaine. So again, within pediatrics, neither of those drugs has any indication because why would you ever want to give a young child a drug that can keep their lip and tongue numb for 12 hours? The risk of self-inflicted soft tissue injury is so great anyway. But when it comes to surgery, whether it's endodontic surgery, osseous surgery, extraction, using long-acting locals like bupivacaine, which you don't have in cartridges, levobupivacaine, or ropivacaine, which are all available in multi-dose vials, yes, for prolonged pain control following surgery, those are excellent drugs.
So there is one more doubt, sir, from a participant regarding the position in the situation of last, sir. You had mentioned supine. Why
Yes.
not left lateral position?
Well, okay, good question. The basic premise, though, for all unconscious patients, positioning, is supine, feet elevated slightly. And what that does is it delivers a good supply of blood to the patient's brain. Now, once the seizure is over, again, I didn't really have the time to go into a lot of detail here, but once that seizure is over, you want to turn your patient on their side, because following seizures, whether it's epileptic or local anesthetic induced overdose, there's a propensity for them to regurgitate. Regurgitation is passive vomiting. Okay, and if the patient is lying on their back in a supine position, if they do regurgitate, there's a risk of them aspirating. If you turn them on their side once the seizure is over, there's less likely, the vomitus would tend to pool in their cheek. It would be less likely to go down into the trachea and into the lungs. So once the seizure is over, turning them on their left lateral position would be okay. But again, I'm sorry, I don't have the time to go into the detail there.
Sir, one question on topical anesthetics, something
Sure.
which will be very fast and effective for children. Some from
Seriously,
your
okay, look, I don't know if you can still see me right now. I don't know if you can, because I can't see you on the screen right now. But if it were legal, the best topical anesthetic is cocaine. Okay, again, I'm saying it with my tongue in my cheek. We can't use it. It's not legal, but it is the best. And the reasons are twofold. Number one, it does numb up that soft tissue. But number two, unlike every other local anesthetic, cocaine is inherently a vasoconstrictor. So there will be less bleeding. Okay, but topicals work. Most topicals are either benzocaine or they're lidocaine in a gel. You put a little bit on a cotton applicator stick. You put it in the buccal fold where the injection is going to be given. You leave it there for minimally 1 minute, preferably 2. And you can puncture the mucous membrane anywhere in the mouth, including the palate, for about 2 to 3 millimeters painlessly. Now, everywhere in the mouth except the palate, once you're in 2 to 3 millimeters, there's no more pain. That's why the palate's a problem. But the point is, topicals work. And to me, it doesn't matter whether it's benzocaine or lidocaine. It doesn't matter, because you've got to leave. You take it 2 by 2. You clean the area. You dry the area. Put a little bit on a cotton applicator stick and leave it there for at least a minute, preferably 2. That's how you use topical.
So it is very interesting to listen from you, sir. Can we take some more questions, sir, if you have time?
Yeah, a couple more.
Thank you so much, sir. So there is a question on whether periodontal ligament injections are
Sure.
contraindicated in primary teeth.
Many years ago, going back to the 1980s, yes, that was true. But now it's in the year 2021. The answer is no. And here's what was thought way back then, because the PDL injection became popularized about the 1980s. And the thought was that if you do a PDL injection on a primary tooth, you might disrupt the development of the permanent tooth underneath it. You might get enamel hypoplasia, for example. That has been totally disproven. So using a PDL on primary teeth is not a problem. But how often do you need it? Infiltrations work. Whether it's in the mandible or maxilla, infiltrations work on primary teeth. And by the way, infiltrations with articaine work, if not as well, better than lidocaine. So I'm going to recommend strongly to you, whomever that is, start using articaine by mandibular infiltration. It is a marvelous drug. But again, PDLs are not contraindicated in primary dentition, but I really believe that there's not that much of an indication for using them, or for using the PDL, actually.
Thank you, sir. Sir, one participant has a doubt. If any changes take place in saliva after giving LA, it becomes quite sticky, he says.
I don't know if you can see me, but I don't know the answer. I've never heard that before, so I won't even venture a guess, because I don't know. Sorry.
Thank you, sir. Sir, the question is on efficacy of articaine versus lignocaine in inferior alveolar block.
There was a paper published. It was the Journal of the American Dental Association, March of 2019. It was, in fact, the cover article. And they compared the use of articaine to lidocaine in pulpally involved teeth, and articaine was superior in every way. Look, when I was teaching, I would tell my dental students, I didn't say to them, this is the best drug. I said, lidocaine, mepivacaine, prilocaine, articaine are all marvelous drugs. What you should do is try them all, and you decide for yourself which is best in your hands. Okay, now I'm retired. I'm out here giving more lectures. I'm telling you right now that articaine is a better local anesthetic than lidocaine, mepivacaine, prilocaine, any of them. It's better. I mentioned briefly that I think it is the preferred local anesthetic in pediatrics. It is preferred local anesthetic in pregnant patients. It's preferred local anesthetic in nursing mothers. It is a marvelous drug. So again, if anybody out there is not using articaine, I would, and by the way, I'm using articaine as a generic name, so I don't want anybody to start to complain that here I am selling a drug. I'm not selling a drug because I'm not mentioning brand names. But the generic product articaine is a better local anesthetic than the other drugs we have. By the way, the other drugs are great, but articaine is just that much greater for a lot of reasons, okay? So yeah, articaine is good. Articaine is good.
Thank you, sir. Our delegates are feeling it as a blessing to listen from you, all these words, sir. And a person has asked about the inferior alveolar-mandibular nerve block technique from you. Actually, there's no time to describe. He wants to listen it from your mouth.
And actually, I would have to show videos and things like that. So, for whoever that person is, I hate this. You mentioned when you introduced me that I have a DVD on local anesthesia technique. Sadly, all of my videos have been put up on YouTube illegally. They're not supposed to be on YouTube. But whomever that person is, just type in my name, Stanley Malamud, inferior nerve block, and unfortunately, you're going to see it. The technique is right there.
So, very sorry for that, sir.
I know, I am too. my family needs the money in these times. I need that doctor to buy my video, not to watch it on YouTube.
Thank you, sir. One last question, sir,
Sure.
on use of local anesthesia along with sedation, sir. Do you have any specific considerations, advices?
Okay, well, you're talking about in pediatrics?
Sorry, sir?
In pediatrics or in general?
In pediatric dentistry.
Okay, so let me ask you this question then. For your residents, are they being taught to use nitrous oxide?
So we have been taught, sir.
Do they use it?
Using, sir.
Nitrous oxide, they do use
nitrous
it. Okay.
Oxide, sir.
Yeah, okay. So the combination of nitrous oxide plus local anesthesia is marvelous. I mean, every study done in pediatric dentistry basically says that over 95% of pediatric dentists, in whatever the study may be, use nitrous. It is a fantastic technique. And in addition to relaxing this patient, nitrous oxide has analgesic properties also. So it helps you to achieve good pain control, even though, again, in children, local anesthesia is not hard to achieve. But that is the ideal combination right there. If you need sedation, I would recommend strongly using nitrous oxide oxygen. The other commonly used technique, which is not nearly as effective, is oral. Oral medications, hydroxyzine is one that is used. And the oral drugs just, they don't work that well. Nitrous oxide, to me, should be the technique that you're using. You should have it in the office, especially in pediatrics, because it works wonderfully if the child will accept the nose piece. The screamer, this might be a child who is in need of going to the operating theater for general anesthesia if you can't manage that. Okay, but nitrous oxide and local anesthesia go very, very well hand in hand.
Thank you, sir.
No.
Dr. Stanley, with your permission, can I introduce my staff to you? They would be very happy. My
You know,
faculty, my team.
for some reason, I cannot see you. I don't know why that's happened here, but wait a minute. Let me try something here. There you are. Hang on. There you are. I see you now. You're standing over there.
Yes.
Wave to me again. Here you go.
Dr. Stanley, this is Dr. Pratima. I would like to introduce my faculty to you. The person who is asking you with the question answer session is Dr. Sangeeta.
Hi.
We have Dr. Suganya,
Hello.
then Dr. Nandakumar,
Good afternoon. I guess still good morning. Yes.
Dr. Kavita,
Hello.
and Dr. Ishwari. And
This
I would
your-
also
your-
like to introduce you to all my pediatric residents.
They're the ones in white sitting around the outside.
Yes.
Hi, everybody.
Thank you, Dr. Stanley. I think this is the moment of our lives to have you on our platform. When we were students and we used to read the textbook on local anesthesia, I never dreamt that, or I never had any hopes that today I would be talking to you. So I'm sure everybody's feeling is mutual.
Thank you. And by the way, for the pediatric residents, pediatrics is a great specialty. I hope you thoroughly enjoy it. It's a great it's a great program. So thank you all very much and have a great day. Have a great Thursday.
Thank you. Thank you, Dr. Stanley. Thank you so much for your time.
I'm going to sign off. Thank you for having me.
Yes, sir. Thank you. Thank you.
Bye-bye.
Bye-bye. Bye-bye.
Bye-bye.
Thank you very much, sir.
Dear participants, on behalf of Team Pedodontics, IGIDS SBV, we appreciate you all being here and thank you for your time. Kindly fill the feedback form to the program and the e-certificates will be generated or mailed to you. Your insights will help us shape the future events. We will also send you a PDF of the lecture along with the participation certificate. I sincerely thank every one of you. Please convey my thanks to even the heads of your department. And I would like to tell you that due to shortage of time or due to the time difference, a lot of questions were unanswered. They will be sent via mail to Dr. Stanley and it will be, he will mail you the answers. So thank you once again for joining us today and we will see you next time. Thank you so much.